Thanks for joining me for another session of Talk Nerdy to Me. It's great to finally have some new content up. I know it's been a while. The COVID-19 pandemic has definitely shaken things up a bit, but I do have a few new ongoing projects that should be up soon. Now, if you're anything like me, the amount of information that we've all been trying to review and process about the coronavirus pandemic feels a little bit like drinking from the fire hose. But since there's already been a ton of time and a ton of effort devoted to creating great resources for information on the pandemic, and this information is just changing and updating so rapidly, I decided that this blog really isn't the right forum to discuss it further, so we're not going to talk about coronavirus today. Instead, we're going to talk about 3 papers that were published recently and do kind of a deep-ish dive into the data to see whether we should or shouldn't change our practice based on them. Real quickly, it's time for my annual disclosure, and I still have no financial conflicts of interest to report. So, moving on. In this talk, we're going to discuss 3 papers. The PRISMS trial, discussing thrombolysis for minor stroke symptoms, the Vitamins trial, looking at vitamin C for septic shock, and CRASH 3, which looks at the use of tranexamic acid for patients with traumatic brain injury. Now, if you've watched any of my other talks, you know that I'm a big fan of the mental break. So about every 5 to 10 slides, you just need 30 seconds of fun to reset your brain and help you absorb more new information. So let's go ahead and jump right into our first mental break, and then we'll get into our first paper. Last year, I offered up some scientific proof that cats are in fact a liquid. Liquids are defined as a substance which assumes the shape of its container while maintaining constant volume. I'm pleased to share with you that I have continued to research this phenomenon and have additional proof to share with you throughout this talk today. With this sample, I provide evidence that cats have a melting point, which appears to be more frequently evident around nap times. Right now, standard practice in the management of acute stroke patients is to rapidly assess the patient and facilitate speedy neuroimaging, and then, if the patient is deemed to be a candidate, initiate thrombolytic therapy or endovascular rescue. Now, I'll go on record here and admit that my own interpretation of the literature sides with the camp that believes that the evidence we have demonstrates that TPA probably doesn't work for any strokes regardless of severity, and that the evidence actually suggests that we may be doing more harm than good, which is why I'm actually quite happy to see that we're gradually starting to shift away from TPA in favor of more endovascular therapy. However, the reality is that skeptics and EBM gurus like me have lost this battle, and TPA isn't going away anytime soon. In fact, what's been happening is that the people who do believe in TPA are continually trying to push the envelope and extend the time window for TPA therapy, expand indication to wake-up strokes, and we're seeing more and more indication creep with little or no data to back it up. However, very few patients enrolled in any of the thrombolysis trials had minor deficits, mainly because of the potential for harm, considering that there is little, if any, benefit to treating patients with strokes that are minimally or non-disabling. The people that support aggressive use of alteplase argue that there is still potential for symptom reduction and may prevent neurologic deterioration in this population, despite the fact that there really is no evidence to back up that claim. The first paper we're going to look at addresses this question. This is the PRISMS trial, published in JAMA. I think it's an important paper that got surprisingly little press when it came out. It's a multi-center, double-blinded, double-placebo, randomized controlled trial that asks whether IV alteplase benefits patients with minor strokes defined as an NIH score of less than 5 without disabling features when compared to aspirin alone. They enrolled 313 patients who were randomized to receive either oral placebo plus IV alteplase or IV placebo and oral aspirin. The primary outcome was the number of patients that had a favorable neurologic outcome at 90 days, and this was defined as a modified Rankin score of 0 to 1. Safety endpoints included the frequency of intracranial hemorrhage, death, and adverse events such as anaphylaxis to the drug. Secondary outcomes included the degree of disability at 90 days measured by the modified Rankin score. Here's a quick recap in case you aren't familiar with the modified Rankin score. A score of 0 is no deficit. With a score of 1, the deficit is so minor that you need a neurology residency in order to find it. A score of 2 is minor deficits, but you can still do all of your activities of daily living without help. With a 3, you do need some help with activities of daily living, but the key here is that with a score of 3, you can still walk. A score of 4 is where you really start to go over the cliff. You need assistance to walk and with all of your daily needs, and a patient with a score of 5 is bedridden and requires total care. With a score of 6, you're dead. They enrolled patients over the age of 18 who presented to the ED with minor strokes, meaning those with an NIH score of 0 to 5, who could be enrolled and treated within 3 hours of symptom onset. Now, they chose a 3-hour window because despite the fact that it is common practice to extend the acceptable window for thrombolysis to 4.5 hours based on the results of ECAS-3, technically it is still off-label use to extend the TPA window beyond 3 hours. Patients were excluded if they already had a baseline neurologic deficit or if they had any contraindications to TPA administration. Patients could also be excluded even if they had an NIH score of 5 or less if the deficit was thought to be significantly disabling, like an isolated severe aphasia or vision loss. Let's look at the results. They enrolled 156 patients to the thrombolysis group and 157 patients to the aspirin group. The mean age of the patients enrolled was 62, and the mean NIH score was 2. Not surprisingly, the results demonstrated absolutely no statistical difference in full status at 90 days. If anything, there was a trend that favored the aspirin group, but this was not statistically significant. It also didn't make a difference in the number of patients that went on to have neurologic deterioration following their initial presentation, with no differences at any Rankin score. As you might expect, this trial demonstrated the same thing that has been shown in every single thrombolysis trial to date, that giving TPA results in an increased rate of intracranial hemorrhage. In this trial, it was over a 2-fold increase. There were more than twice as many overall serious adverse events in the thrombolysis group, including 11 intracranial hemorrhages, 7 of which were symptomatic, and 1 death. This is compared to only 5 intracranial hemorrhages in the aspirin group, all of which were asymptomatic and required no intervention. Treating these patients with lytics did not provide a benefit, and yet if you think back to the last slide, you'll notice that there were twice as many Rankin 4s, 5s, and 6s in the TPA group. It's also worth noting that in both groups, 13% of the patients that were enrolled and treated were ultimately diagnosed with a stroke mimic, meaning that these patients were exposed to a potentially harmful drug with no possible benefit. 13% doesn't sound like all that much until you consider that that's 1 in 8. In the TPA group, there was a 7% rate of intracranial hemorrhage, and a 26%, or 1 in 4, had some kind of a serious adverse event. Considering that all of these patients had minor deficits that were non-disabling, I think we would all agree that any iatrogenic intracranial hemorrhage is just unacceptable. Now, here's the kicker. This trial was stopped early. The authors claim that they stopped it early because they weren't able to recruit and enroll enough patients, and so the sponsor pulled funding. I don't know about you, but I see plenty of patients every shift in my ED that have minor stroke symptoms with a modified Rankin score of 0 to 5. So I call BS on this whole "we couldn't recruit enough patients" nonsense. Now, I'm going to have to put my tinfoil hat on for this section. I think the real reason this trial was stopped early is pretty clear by looking at who sponsored the trial and by looking at the conflict of interest section, where we discover that every single author on this paper is sponsored in some way by the manufacturers of the thrombolytic agent, who incidentally also happen to be sponsoring the whole trial. Had they gone on to enroll the full 948 patients they had planned, at best, this would have been a negative trial. But they were dangerously close to demonstrating harm. The authors reported that they didn't have knowledge of the results prior to stopping the trial, but honestly, I'm just not sure that I buy that. Allowing a negative trial to go to completion isn't in the economic interests of the trial sponsor, but it's a heck of a lot in publishing a trial that demonstrates harm. Had they enrolled the full trial here, there's a good chance that that's exactly what would have happened. Here's the bottom line. This was a well-randomized, multi-center trial that asked a really important question. Unfortunately, it was stopped early and therefore was underpowered for its primary outcome and to assess for safety, and was also fraught with obvious conflicts of interest. This is by no means a perfect study, but it is the best evidence we have to date addressing this question. This paper was at best a clearly negative trial, and actually appears to suggest that there may be some harm when treating patients with low NIH scores and non-disabling strokes with thrombolysis. And so at this point, I think we need to be very careful about considering this therapy in this group of patients, as the best literature we have to date does not support this practice. Here we have another specimen demonstrating typical liquid characteristics within its container. In 2017, Paul Merrick published this retrospective before and after series that reported an absolutely enormous mortality reduction when patients in the ICU with sepsis were treated with a combination of hydrocortisone, vitamin C, and thiamine. They treated 47 patients who had vasopressor-dependent septic shock with the hat trick, hydrocortisone, ascorbic acid, and thiamine, and reported a dramatic decrease in sepsis mortality when they went back and compared them to 47 patients recently managed in the same ICU for the same clinical condition. In the control patients, sepsis mortality was 40.4%, while in the treatment group, mortality was only 8.5%, a staggering 31.6% absolute difference. It's important to note that this was not a trial. It was a before and after case series that was neither blinded nor randomized, and the authors did not recruit consecutive patients, so they were able to handpick which subjects were included. This means there was a huge potential for selection bias in this paper. But if these findings were reproducible, this would be a total game changer in how we approach and manage septic shock. A few weeks ago, the vitamins trial was published, and this is the first of several ongoing randomized controlled trials that were designed to look at whether Merrick's vitamin C, thiamine, and hydrocortisone cocktail worked when actually studied in a more rigorous fashion. This was a multi-center, open-label, randomized controlled trial conducted in 10 ICUs in Australia, New Zealand, and Brazil. They were able to recruit 216 patients with septic shock based on the most current definition of septic shock from the Sepsis 3 guidelines. Their primary outcome was a little bit weird. Instead of looking at mortality, they chose to look at the duration of time alive and vasopressor-free at day 7. What this means is that the patient was alive at discontinuation of all vasopressors for at least 4 hours in the presence of a mean arterial pressure greater than 65 millimeters of mercury at 7 days. If a patient died while they were still on pressors, this patient was assigned 0 vasopressor-free hours. ICU mortality, hospital mortality, and mortality at days 28 and 90 were both secondary outcomes, along with a whole bunch of other stuff like ICU length of stay, acute kidney injury, and so on. Patients were randomized to the intervention group consisting of intravenous vitamin C, 1.5 grams every 6 hours, hydrocortisone, 50 milligrams every 6 hours, and thiamine, 200 milligrams every 12 hours, or to the control group, consisting of IV hydrocortisone, 50 milligrams every 6 hours until shock resolution or up to 10 days. All other care between the groups was standard critical care. Ventilation strategies are designed to prevent ARDS, norepinephrine was used as the initial pressor of choice with vasopressin as second line, and so on. So why did the control group get hydrocortisone? Original MERIT trial, about 60% of the control patients had gotten corticosteroids, and subsequently, the adrenal trial demonstrated that corticosteroid treatment alone reduced the duration of vasopressor therapy. And so they gave the controls hydrocortisone to ensure that any differences they saw in vasopressor days and other outcome measures would not be attributable to the steroid component of the cocktail alone. The primary outcome in this trial did seem a little odd, but this is apparently a fairly common outcome measure in the critical care literature, which makes some sense if what you really want to know is whether a treatment affects your care while the patient is still alive and in the unit. Personally, I would prefer something that's a bit more patient-oriented, like mortality or persistent disability, since those are the things that are ultimately going to matter the most to the patients and their families. Either way, they didn't find any differences in the amount of time that the patients were alive and vasopressor-free. In 7 days, there are 168 hours. In the intervention group, time alive and vasopressor-free was 122 hours as compared to 124 hours in the control group, which did not achieve statistical significance. In this paper, mortality was a pre-planned secondary outcome, and there were no statistically significant differences in mortality at any of the time points they looked at, whether looking at ICU mortality or up to 90 days out. There were also no statistically significant differences in hospital length of stay, ICU-free days, need for renal replacement therapy, or any of the other outcomes that might actually matter. Overall, this was a pretty well-done paper. It was well-randomized, multi-center, and so far is the first RCT to ask the question of whether that combination of hydrocortisone, vitamin C, and thiamine actually worked for the treatment of septic shock. It was open label, which means that the patients and clinicians were not blinded as to what treatment they were getting. However, if anything, that should actually have biased the results in favor of the intervention. So the fact that this was a negative trial despite that suggests that this result is probably the correct one. It was small enough that it was underpowered to detect any significant adverse events or assess for safety. And enrollment of the patients occurred in the ICU, so we don't know how much treatment or other intervention may have been started in the ED prior to being moved to the unit. However, chances are that since all the patients were enrolled in the ICU, any such effect would have affected both groups more or less equally. The bottom line here is that this paper is probably the first nail in the coffin for this cocktail for septic shock. If something seems too good to be true, it probably is. The combination of hydrocortisone, vitamin C, and thiamine was not better than just hydrocortisone alone for the management of patients with septic shock. In this slide, I offer up liquid specimen number 2. In 2013, the CRASH-2 trial was published, and this paper was a big deal when it came out, as it demonstrated a survival benefit when tranexamic acid was given to patients with severe traumatic injury within 3 hours of injury. Unfortunately, CRASH-2 excluded the very population many of us were really hoping to benefit, and that was patients with traumatic brain injury. Traumatic brain injury is a major public health problem and is responsible for upwards of 2.8 million ED visits annually. It's also estimated that there are approximately 5.2 million Americans living with some disability due to brain injury at any given time. Considering the scope of the problem, it's understandable why there was so much excitement when CRASH-3 was published in The Lancet earlier last year. CRASH-3 is a randomized, placebo-controlled, multi-center trial, and it was designed specifically to look at patients with isolated traumatic brain injury, and asked whether or not the administration of TXA could improve outcomes for these patients. It used a pragmatic design, which means that they didn't rigorously control for what happened to these patients outside of the TXA protocol. While from a pure research standpoint that might be considered a weakness, I think it's actually a strength of this paper because it gives us a better idea of how this is actually going to shake out in real-world clinical practice. Their primary outcome was head injury-related death within 28 days of injury. There were multiple secondary outcomes, including all-cause and cause-specific mortality, level of disability, and so on. They looked at adverse events as well, primarily vaso-occlusive events, need for neurosurgery, and adverse events within 28 days of randomization. Eligible subjects were patients over the age of 16 with traumatic brain injury who had a GCS score of 12 or lower or any intracranial hemorrhage on CT scan. They excluded patients with any major extracranial sources of bleeding, and when the study was first started, they were enrolling patients that presented up to 8 hours after injury. But they changed the protocol to a 3-hour inclusion limit after several other papers came out in 2016 demonstrating no benefit and possibly even a little harm to using TXA beyond 3 hours. They made this change without unblinding or reviewing their data, and ultimately, about 3/4 of the patients enrolled were in this early group. They also pre-specified a subgroup analysis that excluded patients that presented with the most severe brain injuries, those presenting with a GCS of 3 or with bilateral non-reactive pupils. The study enrolled 12,737 patients at 175 hospitals in 29 countries. So we're talking about a truly Herculean effort here. About 9,200 of those randomized were treated within 3 hours of injury, but because they made that protocol change, the number was slightly below the author's goal of obtaining 10,000 patients to have a 90% power to detect a difference in outcome. Overall, they had impressive retention of patients, losing only a handful to follow-up over the course of the trial, leaving them with 9,127 patients who were included in the final analysis. Patients were randomly assigned to receive tranexamic acid, a loading dose of 1 gram over 10 minutes, and then infusion of 1 gram over 8 hours, or a matching placebo of saline. Now, spoiler alert, this paper has generated a ton of controversy and, frankly, confusions about what we should do with the data. So let's go ahead and get into the data a little bit and take a look at where this controversy is coming from. They found that there were no statistically significant differences in their primary outcome, which was head injury-related death at 28 days. As you might expect, patients with a lower initial GCS had a substantially higher mortality than patients that had a higher initial GCS. However, even when they excluded patients with an initial GCS of 3 or those who presented with non-reactive pupils, they still didn't find a statistical benefit. The one place that they did achieve a statistical benefit, albeit not a very robust one, was right here. For GCS of greater than 8, they found a reduction in head injury-related mortality, reporting a relative risk of 0.78. When we consider the subgroup where TXA seemed to have a benefit, it does at least seem to be physiologically plausible. When you consider the pathophysiology of traumatic brain injury, your long-term prognosis depends more on how severe your injury is at the start than any other factors. If you have a mild injury to begin with, you're probably going to have a reasonably good recovery because you weren't that sick to begin with. On the flip side, if you have a devastating injury from the start, it doesn't really matter what the treatment is. It's not likely to confer much of a benefit. Giving tranexamic acid to patients on either extreme isn't likely to demonstrate any benefit. The sickest patients are going to be unsalvageable regardless, and the patients with mild head injury are going to do pretty well regardless. The only place where a benefit could really be expected is in the tweeners, those who had a moderate GCS and who may have had a potentially salvageable injury. Now, let's dig back into the data. At first glance, it appears that the authors identified a subgroup where there appeared to be some promise for TXA in patients with mild to moderate brain injury. But here's where CRASH 3 loses its shine. You'll recall that the primary outcome of head injury-related death at 28 days was negative, with no difference between the groups. More importantly, when we look at all-cause mortality at 28 days, there was also no difference, nor did they find any difference in disability scores. What this means is that the reduction they found in head injury-specific mortality in patients with mild to moderate brain injury didn't translate into more people going home or more people having a good functional outcome. The other piece of information that the authors really glossed over was that in the TXA group, the relative risk of non-head injury-related mortality was 1.31. Compare this to the relative risk-benefit they reported for head injury-related mortality in patients with a GCS greater than 8, which was 0.78, meaning that they found exactly the opposite and demonstrated harm for non-head injury-related mortality. Mathematically speaking, if there is no difference in all-cause mortality or head injury-related mortality at 28 days, but you find one subgroup that does better, that has to mean that there's another subgroup that does worse. This increase in non-head injury-related mortality in the folks that got TXA essentially washed out any potential benefit from the drug. Unfortunately, the authors gave this exactly one sentence in the paper and didn't address it at all in their discussion section. And frankly, I think the paper would have been a lot stronger had they done so. The authors of CRASH 3 were very enthusiastic about their subgroup analysis that showed reduced head injury-related mortality in patients with moderate TBI. In fact, the first sentence of their discussion section reads, "This trial provides evidence that the administration of tranexamic acid to patients with TBI within 3 hours of injury reduces head injury-related death with no evidence of adverse effects or complications." This sentence doesn't even sound like it's talking about the same trial. So, despite the fact that their primary outcome was negative and that they found a signal of harm regarding non-head injury-related mortality, the authors still published this as a positive study based on a subgroup analysis. When The Lancet published this trial, they did so along with infographics like these, encouraging the use of TXA because it could, quote, save 1 in 5 patients. That's a frankly outrageous statement because their data didn't show anything of the kind, and this was actually a negative trial. I also have to call them out on their statistical shenanigans that they used to conjure up this 1 in 5 number. They did that calculation using relative risk reduction rather than the absolute risk reduction in order to make the difference between the groups appear more significant than it actually is. When I did the calculation myself, the absolute difference in mortality in their subgroup analysis was only 1.7%, and that translates to a number needed to treat of 59, not 5. And their claim that it saves lives is openly dishonest when there was no difference in all-cause or 28-day mortality. Furthermore, as we discussed in the last slide, the benefit that they're reporting relates only to mortality specific to head injury. But disease-specific mortality isn't really a patient-oriented outcome. I mean, patients don't care whether they die from head injury or from a non-head injury-related problem. They care whether or not they die, period. To be perfectly frank, I don't think TXA is worth all the press it's generated, since we aren't sending more neurologically intact people home from the hospital. Overall, I have to give the authors major props for taking on such a massive undertaking and for doing the trial pretty well. It was a large, multi-center, well-blinded RCT done in 29 countries, which is a truly Herculean undertaking. I completely agreed with using a pragmatic design to mimic actual practice and also agreed with their change to exclude patients with a GCS of 3, non-reactive pupils, and the administration of the drug beyond 3 hours from injury, all of which the authors carefully addressed and explained. On the downside, despite their efforts, this trial was unfortunately a bit underpowered because of the changes they made, which limits what we can conclude. Where this trial really falls short for me is in the analysis. Their primary outcome doesn't match what they registered on clinicaltrials.gov, meaning that they didn't report on the outcomes that they designed the study to look for, and based their conclusions of the paper on an unplanned subgroup that arguably doesn't matter since there was no benefit overall. So the bottom line for CRASH 3, obviously there are some real problems with taking the author's conclusions at face value. This was by definition a negative trial based on their primary outcome, and the only benefit they found was a reduction in disease-specific mortality that didn't translate into greater overall survival or more patients going home with a good functional outcome. Does this warrant further research specifically looking at that moderate injury group? Absolutely. Do I think we should be using this in all of our patients with moderate head injury? Based on my interpretation of this data, no, I don't. Now, I don't think that it's wrong if you feel differently, and if you want to give it to your moderately injured patients. But I don't think that this trial demonstrated enough of a good reason to do this, and it doesn't seem to help more patients achieve what patients and their families actually value: long-term survival and the ability to return home with a good functional outcome. Some would argue that since TXA is an inexpensive drug, there's little economic downside. But if you give a $50 drug to 1 million patients without benefit, that's still $50 million that are being spent on an intervention that could be better spent elsewhere. And I think that the final bottom line from this paper is that we shouldn't prioritize giving TXA to these patients over other interventions that are more likely to be beneficial, like good airway management, maintaining good cerebral perfusion, and so on. And that wraps it up for this talk. I hope that this was helpful and was at least a little bit of a break from the craziness we've all been going through with the COVID-19 pandemic. If you have any thoughts or any questions, feel free to post a comment or post a question. Please stay safe, stay healthy, and we'll talk again soon.